Thank you, Alison. This is awesome. And thank you so much for introducing your panel, emphasizing the importance of communication and coordination, because this panel will touch upon these important issues. My name is Elena Savoia. I'm a principal scientist in the Department of Biostatistics, and I'm the co-director of the Preparedness program at the Harvard THN School of Public Health. We had great discussions today and provided quite a large number of examples, touching upon different types of crises. I heard about Katrina, Mpox, H1N1, the measles outbreaks. So there is quite a bit of variety of situations in public health emergency preparedness that really are require important and capacities and capabilities in terms of emergency risk communication. In this panel, we're going to dive into the public health system to cover the layers of complexity that exist between different organizations and institutions, but also probably the most interesting part of this work, which clearly emerged from the previous discussions, which is the transdisciplinary nature of emergency risk communication, and how every task is interconnected with other public health and also non-public health activities. We will start this panel by focusing on the fact that Western democracies are rule-based societies. Therefore, we need a strong justice system to guarantee democracy and to ensure trust between citizens and governments. We will also talk about the mechanisms that we can leverage to understand the key issues that are most important to the public and navigate the concept of information integrity. So to be able to address these very important and difficult topics, we have an outstanding panel. Our first speaker is Scott Burris, professor of law and public health at Temple University, who will help us understand the complexity of the legal structure and its impact on communication efforts during public health emergencies. Our second speaker is David Scales, assistant professor of medicine at Weill Cornell Medical College, who will speak about the mechanisms that we can leverage to understand the key issues that are important to the public. Next, we have Eve Shapiro, Senior Director of Programs and Evaluation at West Side United, who's going to speak about the experience in Chicago, where equity, preparedness, and communication blended together to address the needs of the community. And then we will close with Dr. Rick Legault, Senior Advisor for Social and Behavioral Science in the Science and Technology Directorate with the Department of Homeland Security, who will close the panel sharing existing collaboration efforts at the national level, focusing on information integrity, research, and development. Professor Burris, I'm looking forward to your presentation. The routine is the same, brief presentation. Please open the floor.
So yes, let me start again. Please accept my thanks for the invitation, and also my many decades of admiration for public health work as I tried to make some useful trouble on this panel. And that's because law and infodemics have a complicated relationship. But at the same time, I really want to start further upstream. Are my slides showing at this point?
They are.
Okay, next slide then, please. The belief that there is a ready-made legal fix for infodemics is a symptom of a broader problem of law and public health. Public health, unfortunately, persists in a vending machine model of law. You decide the solution you want, you put your lawyer coins in, and out pops your law. What we need is more of an organic agricultural model that appreciates how important it is to nurture and preserve legal capacity, how complicated it is to get from farm to table, and how much diverse expertise has to be integrated into practice to make all that work. I think there's an animation you can advance. Law is not just another tool you use to get people to do what you want them to do. It's a facet of your relationship with the population. Legal processes provide opportunities to build and maintain trust, and the efficacy of law depends a lot on how well you do that. We've seen that infodemics can be fueled by legally induced mistrust, and the ensuing cascade of misinformation and mistrust can make it harder to use law effectively in emergencies. Next slide, please. I'm here for a consortium of organizations deeply engaged with the challenge of making law work better for public health. We understand that law pervades public health. It defines authority. It acts as an intervention. It shapes and mediates the social determinants of health. Next slide, please. Public health today pays lip service to law, but it does not seem to take seriously that, for example, pandemic emergency rules are literally a treatment that's administered to hundreds of millions of people at a time. Next slide, please. We in our group anticipated that COVID, like epidemics past and future, would require a lot of legal action. We rapidly mobilized some 50 legal experts to provide detailed guidance in 2 large reports published within the first few months of the pandemic. Next slide, please. In the event, though, the use of law during COVID was not well informed by the wealth of socio-legal expertise that was available. Public health lost opportunities to build trust and enhance compliance in the rules it issued and in the process of issuing and enforcing them. Law failed to prevent health inequities and indeed caused some. Next slide, please. Neither I nor any lawyer given 5 minutes on a panel can begin to lay out the reforms in public health training and administration that are needed to support a high standard of legal performance in emergencies and day-to-day. On the positive side, you've invited public health lawyers to weigh in on the capacities public health needs to deal with infodemics and emergencies. And at a high level, public health as a field has recognized that law is important. So what next? How do we prepare? Next slide, please. This is a legal module we prepared for the essential public health services. It shows the range of tasks required for effective legal action in public health. Each is necessary and not one is sufficient. Policy development is the first step, but policies have to be turned into robust legal instruments supported by required evidence in a form that can get passed and get past courts. Advocacy and education to get good legal ideas enacted is also part of public health practice, and so is properly implementing them and helping defend them against legal challenges. Finally, and going back to my treatment analogy, it is crucial that we timely assess the effects and side effects of these measures to ensure that they're effective and equitable in operation. This more detailed account of legal functions highlights some key points. First, non-lawyers do most of this law-related work in our public health system, yet they get virtually no training in how to do it properly. Secondly, law is where the rubber of equity meets the road, but it's less about the legal words on paper than in what you do. Designing and fighting for policies provides a crucial opportunity to engage policies and build public trust, as we've heard just in the last session. Most inequality happens in enforcement, a process people in public health are not trained in or think much about, and inequalities persist because we don't evaluate legal implementation and effects quickly or rigorously enough. So allow me to apply this to infodemics. Can law limit or prevent them? Not in the vending machine model. Law can do little about misinformation coming from elected officials and their staff, and First Amendment doctrine has left governments with few weapons to contain misinformation coming from outside government. But an organic farming approach could help. Making better decisions about when and how to use law in emergencies could make law more likely to win public support and better able to address mistrust and resistance. How you do this is a long story that many public health law experts keep trying to get you to listen to, and that time prevents me from rehearsing here. Things would be different if everyone in the public health system had the capacities necessary to deliver the 5 essential public health law services. We could approach policy design with a greater understanding of the challenges of legal implementation. We could draft laws that are better designed to avoid resistance. We could better explain and implement the rules we enact. We could anticipate how misinformation can affect the implementation stage by, for example, amplifying a vocal minority to the point where legal tools go unused for fear of backlash. We can be accountable through timely evaluation of our legal efforts. Next slide, please. I hope that these brief comments drive home the point that law is not some consumable you pull from a machine. It is in fact a social behavioral phenomenon that is not different in kind, in complexity, from other sorts of processes public health professionals work with every day. Understanding how this process works and knowing how to do one's public health part of it is essential for everyone in the workforce. The best way to build trust and compliance in health law is to design and execute it competently. And is there a better way to build trust with the public than to show that we can use law effectively to solve major social problems? Thank you.
Thank you so much. I love the examples of the vending machine, right? Excellent. Thank you so much. And we will definitely come back towards the end of the panel. I think it's not enough time to address such a very complex issue. Our second speaker is David Scales. David, what mechanisms can we put in place to enhance some capacities here in terms of understanding what the public is prioritizing?
Thank you so much, Dr. Savoia. It's an honor to be here. My goal today is to talk about event and indicator-based surveillance to track infectious disease outbreaks, which might sound like a little bit of a strange discussion to be having when we're talking about infodemics and misinformation and rumor monitoring. But my goal here today is to try to assess a little bit of a dilemma that we have in a democratic society, which is where public health is the domain of a lot of our governmental responsibilities, where public health is responsible for detecting and responding to outbreaks that affect human health. And the infodemic falls under that. But if we're doing infodemic surveillance, that kind of creates a discomfort that the groups like government that are usually responsible for public health might need to get involved in doing the surveillance of information, which starts to get into questions of freedom of speech, questions of censorship. So I think we can draw some lessons from event and indicator-based surveillance in tracking infectious disease outbreaks to learn how we might be doing rumor monitoring for infodemic management. Next slide, please. So Health Map, you have to put yourself back in about 2014, but Health Map was recognized by the Associated Press and a number of other journalistic outbreaks for having detected the West African Ebola outbreak in 2014 earlier than a lot of official organizations detected the outbreak. They also were recognized in 2016 for detecting Zika earlier and with surprising accuracy. And HealthMap wasn't alone. In full disclosure, I did my postdoc at healthmap.org, so I'm very familiar with the work that they did at Boston Children's Hospital. And that's why I think it can be applied here, because other digital disease detection groups that did event-based surveillance also had similar successes. Next slide, please. So digital disease detection and event-based surveillance is based on the principle that we can detect epidemics earlier by monitoring news, by monitoring what people are talking about. And that's by doing data collection of various different news sites, broadcast, newspaper, even social media, collecting all that data, processing it, and then turning all of those insights gleaned into alert notifications. This process was started approximately in 1994 by the Global Public Health Information Network in Canada. And it was various different innovations came along through the process. So HealthMap, for example, put things, after all of this intelligence was turned into alert notifications, put those alerts on a map. EpiSpider, Biocaster, Medisys all had different kind of innovations, either in data collection or data processing. Next slide, please. But there are trade-offs. So event-based surveillance, it does certain things very well and other things very poorly. So its main objective is early warning and outbreak detection, and it does that very well, as those newspaper reports of HealthMap mentioned. To do that, it uses sources that are both official and unofficial. It needs to use social media, broadcast, print. It needs to be hearing the rumors that are going around. But because of that, its credibility is sometimes suspect. The things that are going onto these maps or into these systems may or may not actually turn out to be events after investigation. But it's important as a signal that perhaps needs to be investigated. Because of that, it tends to be very fast. It's rapid. There's constant updates, sometimes on the hour, every hour, usually automated systems. And these systems are usually run by stakeholders that are outside of government. academia, NGOs, usually in partnership with governments. And so a little bit of the punchline of this talk is while HealthMap detected the Ebola outbreak 9 days before an outbreak was declared by the World Health Organization, there's a large amount of data sharing. And so the minute HealthMap knew of that outbreak, so did the WHO, so did the Centers for Disease Control, and all of the other governmental partners. But the key was HealthMap was one of the first to essentially put it on a public map. Now, in contrast, indicator-based surveillance has a bit of a different purpose. While it does do some outbreak detection, it's also really important to inform public health response, to monitor trends and risk over time so that governmental organizations that are responsible for outbreak response can allocate resources accordingly. The sources tend to come from more official, concrete sources, things that you can really hang your hat on: physician diagnosis, laboratory confirmed studies, sometimes emergency room chief complaint data. Because of that, the credibility tends to be a lot higher, but the speed tends to be variable, often a lot lower. To give an example, the CDC's influenza-like surveillance tracking, which tracks essentially emergency room visits and symptoms that correspond with influenza, has a 3-week lag time, which if you're trying to get out ahead of an epidemic, that can sometimes feel like a long time. The responsible parties ultimately tend to be local, state, and federal government. It's not that these two groups in event-based and indicator-based surveillance don't talk to each other. It's that there tends to be a little bit of a separation. And the reason for that is, as I'll talk about in the next slide, please. So one of the major important factors in separating these two, even though the Venn diagrams overlap, is that defining event is a very challenging thing. So when you have event-based surveillance done by academic and NGO partners, it makes it very simple because it leaves each system to define event in its own way, or whatever way that it thinks is most important in that moment. They can be very agile in that definition, and they can change that definition even as a public health event of international significance evolves. That flexible approach allows academic and NGO partners to cast a very wide net, but it doesn't give credibility to rumors that are circulating, because those rumors that are circulating appear on an external website or an external resource. An example that I like to give of a situation where this isn't working well is the vaccine adverse event reporting system. Now, this is an event-based reporting system. It's in the title, a vaccine adverse event reporting system, but it's housed by the Centers for Disease Control, and anybody can contribute to it. They can contribute any adverse events to it. And the challenge about this is now this is an event-based reporting system with all the caveats that people in public health are aware of, that, the credibility is suspect, it's very rapid, but we can't necessarily hang our hat on the data that's there, but it carries the imprimatur of the CDC. So because it has that overlap, there's certain people that assess high credibility to these data when we can't necessarily say that they have high credibility because they've not been investigated. So there's some confusion there, and there's been a lot of misinformation that has leveraged that slippage in understanding about the vaccine adverse event reporting system. Next slide, please. So I think this is important for public health professionals that are interested in working in infodemic surveillance, as we call it, or rumor monitoring, as Dr. Starbird kind of recommended, because infodemic surveillance is event-based surveillance. We do not know the credibility of a lot of these rumors that are circulating, and it makes it very difficult to define things like misinformation. And I'm not necessarily sure that we always want our government to be defining kind of what is true and what is false. Now, that said, I think our government can build and leverage partnerships with academic and NGO partners outside of government who have the flexibility to leverage those definitions in ways that they see fit. And then I think that also allows us, as we have more time, more data, and more evidence, to define indicator-based surveillance for infodemics that our government partners can do in ways that are not necessarily controversial, such as monitoring and reporting claims that are widely agreed to be false and have high potential public health consequence. And some examples might be COVID-19 vaccines contain microchips, which they do not, or there's a lot of rumors about how they might affect fertility, which the evidence does not suggest that they do. But these are things that might be very useful for an indicator-based surveillance to focus on. And with that, I'll leave questions at the end of the panel, and I look forward to having a longer discussion with you all. Thank you.
Thank you. Thank you so much. Maybe we can touch upon later on how you build those indicators, right? It's also probably that's the main challenge. I will turn it now to Eve Shapiro, who will talk about the experience in serving communities in Chicago.
Thank you, and thanks for having me. So as Elena mentioned, I'm going to share a little on how community organizations and leaders can be effectively included in the ecosystem of infodemic management, specifically through the lens of our approach to COVID. So for a little bit of background, my organization, Westside United, is a health collaborative that's composed of 6 anchor hospitals, as well as a wide variety of community partners. So we already come from this perspective of valuing and seeing the impact of cross-sector collaboration and the necessity of putting community members and their voices at the forefront. So in April of 2020, Westside United was invited by the Mayor's Office of Chicago to convene a group of community organizations and leaders to support the flow of information between city government and neighborhoods. So at this point, there were a handful of neighborhoods that had been more dramatically impacted by COVID, and most COVID deaths, I want to say upwards of 90%, were among Black residents in these neighborhoods. So it was very clear that there were immediate disparities in mortality, and the city decided that the best approach would be to create a clear line of communication with trusted community leaders and organizations. So as a collaborative, we established the Racial Equity Rapid Response Team, which is a data-driven, community-based, and community-driven mitigation effort to reduce illness and death from COVID in Black and Brown Chicago communities. So we had a few key strategies, which included providing education to residents on how to reduce transmission, as well as the dissemination of material resources like PPE, testing, and support services. So I'm going to talk a little bit about our structure and why the composition of this response team was effective at improving communication throughout the pandemic. So we had both an internal and an external component to this team. On the external side, we had 3 working groups that supported our strategies. So the first was a communications group, and they focused on developing COVID-19 prevention messages and materials for priority audiences in those specific neighborhoods that were more impacted by COVID. We also had a provider group that was focused on building responsive testing and treatment strategies. And then finally, we had a community response network, which was composed of CBOs who provided direct services to community members that were impacted by COVID. So one big challenge was that these 3 working groups had pretty different membership. The communications group was the city, the provider group had hospital and FQHC leadership, and the community response network was composed of these community-based organizations. So these groups therefore had really different vantage points of what was going on and access to very different information about the pandemic. So in order to breach these silos, there was an internal structure that was composed of a steering committee along with the data and resources working groups. And chairs from those 3 external work groups would participate on the steering committee and be able to bring sort of on the ground knowledge and challenges to the broader structure. The steering committee met weekly. Those working groups also met weekly. There were also cross work group communications. And I think one major lesson learned is just how much time and intensity of effort it takes to make sure that all the relevant parties have sort of consistent information. I just want to give a couple examples of the way in which our team structure really improved the quality of information that was shared about COVID. So one thing, I think we've heard a little bit about this, where there were a lot of myths that arose at the beginning of the pandemic about how to keep safe and prevent transmission. So the communications group, which was in charge of spreading information about preventing transmission, worked with the data work group and the community response networks to survey a sample of community members to better understand perspectives and beliefs about COVID. And this helped the communications group hone their messages and address those myths and provide relevant information. I'd also say in this very rapid environment, the communications group wasn't able to market test any of their messages really. So this community group was really a place where they could do like rapid testing of the messages and get quick feedback to hone things before they went out to citywide audiences. And last, I just want to emphasize the importance of the community networks at this table. So they were able to say kind of exactly what was working and wasn't working in their neighborhoods. And one example was that the city had like thousands of face masks that they were going to distribute to these priority neighborhoods. And the community network representatives were able to say, these face masks are all white. The people in our neighborhoods would actually prefer black face masks and are probably not going to wear the white ones that you disseminate. And so the city was able to adjust their resourcing accordingly. So these cross-sector approaches really enabled the city to better understand community perspectives, and the bi-directional flow of information supported better communication. Thank you.
Thank you. Thank you so much. We will now turn it to Dr. Legault, who will talk about information integrity and research development in this area.
Hi, thanks, Elena. So, listening to, as I've been able to pop in and out of all the presentations today, listening to all this has been fascinating. And I think am I the last presentation today? No pressure. So my goal here is to widen the aperture a little bit. So as Elena mentioned, I'm the senior advisor for social and behavioral and sciences and economic sciences at Department of Homeland Security. And of course, we have an incredibly broad mission. When you think about the importance and value of effective risk communication and the importance and value of good information that has high integrity, which I'll talk about in a minute, and how poor information, misinformation, and disinformation can have an impact on the breadth of what we do, and more broadly on the country. One can certainly easily think about a gamut of scenarios, from major public health or natural disaster response to all the way to violence prevention, or information about immigration laws and the border and the strains that puts on the United States. So I think there will be a link in our information. Last December, the White House Office of Science and Technology Policy published a research and development roadmap on information integrity. And so public health is a huge part of this, and so is national security. But I think I'd like to widen the aperture even further. As we all think about the information ecosystems in which we exist, and the richness of data that's available about each one of us and how we consume data that generally goes to private interests, and how those data can be used, it is sort of an all-encompassing problem across a number of what I would say are very clearly bipartisan issues, like commerce, elder fraud, families, youth vulnerability, and broader social and equity harms, and then also national security and health. I think the fundamental environments in which information exists and is consumed, as well as how people consume that information, how we measure these concepts, and how we think about the reaction of people to information, both in a short term. A lot of medical people here thinking about dosages over time. In the long term, when you're used to consuming information in a very specific way over a very long period of time, and your individualized preferences for information consumption and what that means to how you deal with being presented with new information. I think all of these very, very fundamental questions would not only impact public health and national security, but all of these other areas that we're talking about here today. And so fundamentally, from a scientific perspective, I'm really, really interested in not only the information ecosystems in which we currently exist, but in the near and long term, what are the information ecosystems that we'll be operating in the future? And will they be different or the same in terms of measurable outcomes in observable behavior, whether that's a choice of whether or not to receive a medical intervention or use a medical intervention, or a choice of whether or not to evacuate in the face of a hurricane or a major natural disaster. All of these things I think are very important and are likely to be pretty fundamentally impacted by the same set of underlying questions. And then of course, getting much better at clearly, consistently measuring the impacts of the actions and communications that are taken by third parties or intermediary organizations, be they federal, state, or local public health organizations, security organizations, police, or non-governmental organizations that are attempting to assist the public during some type of an emergency. I really think we don't have sufficient clarity, nor do I think research is able to do a very good job right now at keeping up with the rapidity of change in those information ecosystems to be able to clearly always measure these outcomes. And then, of course, there's always the difficulty of somehow connecting online behavior and information consumption, either at a group or an individual level, and the behavioral outcomes that are much more easily observed. So some of the goals that I think are important in a partnership between government and industry and universities and private interests include fundamentally understanding and measuring what fidelity or integrity of information is, which I know we've heard some people talk about today, how we understand and measure resilience to different types of negative or low fidelity information campaigns, which I've also heard some people talk about today, what the effects of those interventions are, and what it might mean to grow trusted, beneficial information ecosystems culturally, what that might mean and what those outcomes might look like. Questions remain. I think in this area, it's nascent. There's a great deal of controversy. Who should be sponsoring this kind of work, from where, answering exactly what kind of questions. And I think those types of questions within the scientific community and the government scientific community are largely in some places still up in the air, but I think they're important questions that we need to answer together as a scientific community in the U.S. And ultimately, I think it will be a very broad medical socio-technical endeavor that will finally allow us to systematically measure some of these things that we're interested in, be able to connect them to the outcomes, ensure that we understand theoretically how these changes in behaviors are driven, and to be able to adapt quickly to new changes to information ecosystems in the future. In closing, I just want to thank the chair and the organization and everybody on this panel and all the other panels for your time today. Everything has been really fascinating to think about for me. Thanks for
Thank you, Dr. Legault. In this last 20 minutes, 25 minutes that we have, I would like almost to accomplish a impossible mission. I would like to bring all the panelists together to think about outcomes. So, Dr. Legault, you mentioned outcomes, and really inspired by Eve's presentation on equity, issues around equity. How what do we need to do to improve equity during large-scale emergencies, focusing on the issues that you have discussed? So, Professor Burris, you mentioned along the path of important steps in better integrating law into public health. Where do you see the greatest gaps? How can we fix it?
Well, having watched a bit of the proceedings today, I go to that idea of transdisciplinarity. Preparation is important, but ultimately emergencies present questions of judgment, large and small, day to day. And they push us to try and have a long-term strategic eye, even as we manage problems that are blowing up in our faces right at this moment. To have the 3 press releases written, except to have the 3 press releases written for the next 6 months or 8 months, to understand what the important time frame is. With that kind of, I don't think it's possible for anybody to prepare individually for that kind of job. But there is so much that we collectively know. And even within the health department, within CDC, there's so many people who understand pieces of the puzzle. And the challenge is to try and mobilize that knowledge during those, sometimes days, sometimes weeks, that you have the impetus as the public health agency, when people are going to listen to what you say and figure out what's the right thing to say. And that includes, I think, building time, and that, of course, means building on, but also re-triggering those relationships that Dr. Shapiro talked about. You have to understand that the process of crafting a response is going to take some time with people who are experiencing the problem. And that unless you have the experience, unless you have the voices of people who are delivering the food, or who are being the first responders, who are working in the hospitals, unless their voices are guiding your plan is not going to be as implementable or as strong as it should be. So it's transdisciplinarity and mobilizing transdisciplinary knowledge that I think is our biggest challenge. And that's about the processes we use to make decisions and who we bring to the table. And that is where I think we really need to see some change. Less haste, more speed. Sort of the notion.
Thank you. Professor Scales, you're very well described the techniques around surveillance and what we can learn. How do we improve our ability to identify what is really important to respond to? And you were talking about indicators. Is there mechanisms that we can leverage to use those tools to respond in a more equitable manner?
Yeah, thank you, Dr. Savoia. I think that's a really important question. I think there's been a couple of really interesting examples during the pandemic that I think we still need some way to aggregate these examples, because these weren't necessarily kind of published in peer-reviewed journals. Some aspects of them have been, but I think there's a lot of stories of really successful community-based initiatives that have essentially done some level of event-based surveillance at a community level. I think of things like I Heard St. Louis, which collected rumors that were circulating in the St. Louis community and responded to them. I think of in Chicago, Dr. Arwity's Facebook Live programs that she would do weekly, essentially with people bringing in the rumors that they were hearing at any given basis during the pandemic and responding to them in real time. And I don't necessarily think every public health department has to do that, but I think the utility of that type of community-based listening and not just listening and responding immediately, but kind of looking at the trends over time, understanding it from an epidemiological perspective, I think is really important. We've seen the NIH's Community Engagement Alliance, the SEAL program, and Information Futures Lab at Brown University has also done a number of really interesting things with a recent report that they came out with called The Case for Investing in Vaccine Demand. And one of the perspectives that they take that I think is really innovative, and it builds on this idea of surveillance event-based surveillance, is really trying to focus on community information needs rather than just focusing on misinformation or rumors, but stepping back. And the public health analogy is essentially like, rather than just focusing on the epidemic diseases and kind of like from a public health perspective, flying in to do kind of disease outbreak response, but it's really trying to address kind of the public health needs of the community in a preventive way. So, the analogy would be, rather than flying in for a cholera outbreak, what are the sanitation or the hygiene needs of a community? So when we think about it that way, we can remove misinformation in some way, kind of from the equation, if we're specifically trying to turn it around and understand from the perspective of the community what information needs they have and what we can do as partners to kind of help them meet those information goals.
Thank you so much. And I would like to turn a similar question to if Shapiro, you have so much experience on the ground. And my question is, how can we be more proactive? How important is to be proactive?
I would say it's very important. I think kind of in line with what Dr. Scales was saying, it made me think about the importance of not just preventative work, but like ongoing trust building and engagement with community. It reminded me of, I did a focus group kind of midway through the pandemic with some young people in one of our priority community areas. And it wasn't about the pandemic, but they were describing like, they were saying like, they want us to wear these masks. They want us to like, wash our hands, do all this, but like, they haven't been here addressing the violence in our community, addressing the unemployment in our community. So I think, it's sort of an impossible task, but you need to have these like ongoing relationships that really show that, government and organizations and business are all invested in the success and well-being of the community beyond the specific incident as it's occurring. So I think that's one great way to be proactive. Another thing we did was work on capacity building. So we started each of our sessions with a review of the data, but we had folks in the room who were from the Chicago Department of Public Health. We had folks from community, we had folks from clinicians. And so what I did in my role is I took data from the Department of Public Health and sort of reworked it and tried to explain, I don't know how successful it was, but I tried to explain it in a way that was accessible for everyone and showed, we also did a couple one-on-one sessions around capacity building and like data interpretation and management for some community members. And that enabled them to kind of like take things into their own hands. They were able to look up incidents of COVID and hospitalizations and see where things were tracking in their neighborhood and react accordingly, not necessarily through us. So it kind of removed us or the Department of Public Health as like a barrier for their own empowerment to make successful choices for their community.
Thank you so much. And the example that actually you're providing related to priorities at the community level, which not necessarily may be public health priority. That brings me back to Dr. Legault, when you were mentioning, the importance of not only cross-disciplinary work, but also agencies working together, speaking different languages. What has been your experience in this field? Do you think we making any progress?
So I have had personally both nationally in the interagency and internationally, I'd say that there is a really broad recognition of this topic as something that's really problematic and very harmful. Exactly how everyone moves forward and decides what their role is in supporting work in this area, I think is something that a lot of agencies are still trying to figure out. And we have so little control, right? We know so much, but we have far less control than many people would give us credit for as the federal government, the all-seeing, all-knowing federal government of conspiracy theories that we all study and read about. So one of the great benefits, though, of working in those cross-disciplinary environments are different perspectives that can be brought to bear, both in how we think about individual problems as well as really, really big problems. And it's interesting, one of the ways this is not a government problem, right? Certainly it is the business of government to do its best to prevent fraud and to ensure that people have access to information and transparency and these types of things. But the environments that many of us are talking about here today that I think are driving the information ecosystem that nobody can describe very well because all the data are private are largely big tech companies and not the government. And they're also sponsoring a lot of research in this area. And this is my personal opinion and not the opinion of the Department of Homeland Security, but I'll share with you my public health inspired viewpoint on this. Those companies are investing massively in research to prevent obvious harms through these information ecosystems. But all of the research points towards the users producing content, and nothing points towards the enabling functions of the information environments that are owned by and the algorithmically driven information consumption that are driven by these companies. And it does put me in mind of the research centers established by tobacco companies in the 50s to tell everybody that tobacco is, not really harmful. And it was only later on when the government and public health community did invest heavily in research in this area that it was discovered that you couldn't really trust all the research that was being sponsored by the tobacco companies on the topic. So, there might be an element of that going across all of these things as well. It is a brave new world of information consumption and driving engagement with information and presentation of information is in fact the fundamental underlying business model of a lot of these companies. So I do think eventually we'll discover that figures into the problem in some significant way, that when we look back on meetings like this, that we'll be surprised that more of us weren't talking about it more openly.
Thank you. Thank you so much. In these last 10 minutes, I would like to ask each panelist to give us 3 takeaways from your presentation that you would like to share with the public health audience, taking into consideration that there is a variety of agency, the local, state, federal, tribal level that we are communicating with right now. So I will start with Professor Burris.
Thank you. Well, I want to have an optimistic takeaway on a number of fronts. I think, first of all, we've never had greater capacity in public health academia and research generally in technology to study and research the effects of laws on health. And we've never had the information capacity, the network capacity to bring together so many different disciplines, to work in a truly transdisciplinary way, to start thinking of ourselves as engaged in a sort of social problem-solving enterprise that necessarily draws upon collaboration, discussion, and different perspectives, and gets good at putting them into practice in a time-sensitive, timely way. I think that can be done, and I think that the wonderful thing about doing that, and the wonderful thing about public health, is that generally speaking, what's truly good for the health of the public is generally also going to be equitable, and it's going to be socially just. I don't think that we have a failure of conceptual concern or data support for understanding equity. I just don't think we're very good at doing it on the ground. And yet there are so many people, and we've seen them on this panel, who actually do it every day and do it really well, and who could do more if we gave them more of a shot and if we brought them more into to decision making. So my takeaway is we can do a lot better job building trust during pandemics through the legal process and through the application of legal powers, if we're willing to try and if we're willing to change. That is always the caveat, but the opportunity is there.
Thank you so much. Let's keep the optimism going. And David Scales, what are your optimistic views for the future?
Sure. Well, I think one of the things that we learned during the pandemic was something that's come up a couple of times during these panels. One is, it was mentioned by Tom Wilkinson in the last panel, and also mentioned by Eve Shapiro here in this panel about the need for these longitudinal relationships over time. And I think we are recognizing just how important they are, and we can't let them essentially wither on the vine with all of these relationships that were built during the pandemic. And I think, in terms of takeaways from my talk that I think we can leverage here is that, event-based surveillance, kind of doing rumor monitoring that we're already doing is the kind of thing that is only improved by having stronger relationships with communities, because then it's not necessarily kind of collecting information about the communities, but it's about collecting information with communities to kind of meet their needs. And that's I think a perspective that I think we need to really shift towards as we do some of this rumor monitoring in public health. Because I think we're already doing a lot of this rumor monitoring and event-based surveillance, and we already have these collaborations with communities. I just think we can make the arguments that these need to be strengthened and fertilized over time so that we can kind of keep some of the successes that we had during the pandemic, not just going, but growing and propagating to other places.
Thank you. Eve Shapiro.
So one thing I'm optimistic about is that in Chicago, we saw an evolution from the membership of the Racial Equity Rapid Response Team to folks who are kind of leading Healthy Chicago 2025. So the same community-based organizations and other community-based organizations were given additional resources to do community-led assessment and intervention. So I'm really hopeful that we can continue investing in community-based approaches and just allowing community members and trusted leaders to be the authorities for kind of what is going on in neighborhoods. I also really liked, I think it was Scott Burris who said, be speedy, not hasty. And, building relationships and effective channels for communication takes time and effort, but I think at the end is really worthwhile, come the next pandemic, hopefully not for a long time. And finally, I think it's really important to trust community to be authorities on their own experience. Doesn't mean that everything everyone believes is right, but it does mean that they know a lot more about themselves than you or anyone else does. And it's important to kind of get to that nugget of truth.
Dr. Legault?
In a broader sense, I think eventually at a social level, we'll adjust to this new information environment, whether we do so quickly and peacefully, or we do so in scenes akin to the horror that followed the proliferation of the printing press and the Protestant Reformation, are open questions. But I really do think that the way information proliferates today is as big of a seismic social change as that period of fairly recent history that I just mentioned. And hopefully we're a bit smarter now, and we can all come to agreement on what are the concepts that are important to measure, how do we measure them, how do we share that information, and then how do we capture the types of interventions and outcomes across the broad range of experiences that everyone has at all levels of interaction to be able to drive better, smarter outcomes that are better for society writ large in the future.
Thank you. And again, I really love that outcome-focused approach. Thank you so much. It has been really my honor to moderate this important session with high caliber expertise. I really would like to thank every single one of you who participated, the NESM team for their leadership, and definitely, obviously, CDC for the opportunity to bring this topic to the front line of the public health debate. Very important. And I will turn it to Professor Howard Cole for closing the day and let us know what's happening tomorrow.